This is an extreme close-up, but we're not talking about that today. Welcome to So we're going to kind of finish up cardiovascular stuff with kind of just a potpourri of different vascular things. And we'll start with Raynaud's phenomenon, a paroxysmal peripheral arterial vasospasm. Isn't that interesting? So take a look at the picture. You see how in the picture the person's fingers have gone white? So the arterioles have clamped down, they've gone vasospastic, and they have reduced blood flow distal to the area of vasospasm. What the heck is going on in this thing? Not exactly clear. Even though Raynaud's phenomenon has been known about for over 100 years, we still don't have the best explanation for it pathologically. We do know, however, that Raynaud's is basically too much of a normal response. There's a lot of research looking at the sympathetic nervous system and specifically alpha-2 adrenergic receptors. However, we don't have a clear pathophysiologic mechanism for this. One of the reasons why research might still be a little bit lacking is that in most patients with Raynaud's that you experience, they'll know triggers. Maybe it's the cold, maybe it's stress. But for the most part, it's temporary, and in a lot of patients, it resolves on its own. I have had a handful of patients that do take medicines for Raynaud's exacerbations, but I've had a lot more in whom medication treatment is not necessary. One other interesting thing about Raynaud's phenomenon is that it can be an associated disorder diagnosed around the time of another autoimmune disorder being diagnosed. But again, the connection between the two is not strong. So we've talked a lot about atherosclerosis and plaque and fibrin and thromboses and whatnot. Thrombophlebitis obliterans, also called thromboangiitis obliterans, also called Berger's disease because, hey, why wouldn't you want to name yourself after thromboangiitis, right? Yeah, of course, I would. Yeah. Is there a disease that I could put Kieran on to? So the interesting thing about thrombophlebitis obliterans is that it's this pro-inflammatory thrombotic or thrombosis-forming pathology that distinctly does not have atherosclerosis or that process of atherogenesis as an underlying mechanism contributing to the thrombosis formation. The other interesting thing about this is that the thrombi become so large that, as the name implies, they obliterate or completely block blood flow. And you can get areas of significant redness, swelling, pain, and even tissue death. The other thing that I think is actually kind of fascinating about this particular disease is that it's almost exclusively found in smokers or people that consume tobacco. If you're going to ask me about vaping, I haven't seen any studies yet. That'll be interesting to watch for in the future. Now, clinically, when you look at this, I gotta say, it's really hard to tell the difference between a thrombophlebitis obliterans case and, say, a case of staph cellulitis, Staph aureus-related cellulitis. So if you look at the foot picture here, if that foot were in your clinic, I could almost guarantee you a staph-related cellulitis would probably be the default thing people would think. even in the presence of somebody who smoked. But if it didn't respond to antibiotics, then the suspicion of a thrombophlebitis phenomenon goes up. Deep vein thromboembolism, or DVT, is a massive problem in the healthcare setting for patients. This is something that you'll deal with your entire nursing career. For Child-Stride is the classic theoretical explanation for why people develop DVT. So as patients develop venous stasis, vessel injury, or hypercoagulability, those three things increase risk for DVT to occur. However, you don't necessarily have to have all three of them to develop a DVT. They're just considered the three factors, and each one of them raise DVT risk. Now, since DVTs most often occur in the leg vein, the clinical presentation is down in the distal lower extremities and can include lots of inflammatory signs such as warmth, redness, swelling of the vein or ropiness, and this thing called Hohmann's sign, which you'll learn in your assessment class. And what Hohmann's sign is passive dorsiflexion of the foot by you, the healthcare provider, to see if you can elicit discomfort in the patient. I know, sounds mean, doesn't it? A lot of assessment is like that. If DVTs are suspected clinically, the next step is to do a diagnostic workup. Ultrasound is the most popular imaging modality to look at the veins of the legs and try to find DVTs. If for whatever reason ultrasound is unavailable, CTs or MRIs can do that as well. However, you're spending a lot more money. And in patients who develop DVTs, I should mention three standard tests for blood clotting time. PT, prothrombin time, PTT, partial thromboplastin time, and INR, the International Normalized Ratio. Three very popular blood tests to look at normal versus abnormal blood clotting time. The first thing I want to tell you about this is please don't think you have to memorize the coagulation cascade for this class. You already learned it in A&P. I'm not retesting you on it now. However, treatment for DVTs are blood thinning drugs. And blood thinning drugs do work by intercepting the coagulation cascade at various points within that cascade. So at the very least, if you have patients treated for DVT, you should at least know that the treatments that you will give to those patients work by stopping the blood clotting process. The other thing that you should know is that DVTs are typically treated for a period of months with blood-thinning drugs. People are not put on blood-thinning drugs indefinitely. After a period of months, typically the clots within those leg veins become so affixed and so hardened that the risk for embolization, for example, embolization from the legs up into the lungs, grows very small, and the person can safely be taken off of anticoagulant drugs. What if your patient has a DVT and can't tolerate blood-thinning drugs? Maybe they're a big fall risk, and if they're on blood-thinning drugs, they could fall and bleed to death. Well, there are other things you can do for DVTs too, and an inferior vena cava filter might be an option. As the name implies, it is a filter in the inferior vena cava meant to physically catch DVTs that have broken off and embolized and are at risk for traveling to the lungs and becoming pulmonary emboli. However, filters are not without their own risks, and you can see them listed here. They can poke through a vein. They can migrate up or down. The devices themselves can actually promote thromboses. So you gotta weigh the pros and cons of these treatments.
I'm looking down at my leg and I'm overwhelmed.
Venous insufficiency and varicose veins are, generally speaking, the result of either damage to the vessels or lifelong stresses on the venous side of the vasculature. Obesity is a risk factor. Sedentary lifestyles are a risk factor. Desk jobs are a risk factor. People with chronic venous insufficiency can develop a condition called stasis dermatitis, whereby the increased hydrostatic pressure within the veins, typically of the legs, causes excess fluid to leak out into the interstitial tissue or the third space. And when this happens chronically over a period of years, the area around the leg can have this kind of dark, dusky appearance to it. Varicose veins are just basically venous insufficiency in the superficial veins, the ones that we can easily visualize. There's poor venous blood return back to the heart. The veins' pressure increase, and you can see them. All kinds of treatment for chronic venous insufficiency and for varicose veins. Pressure stockings. There are pressure stockings you can buy over the counter at any local pharmacy. There are prescription strength ones where people have to kind of measure and fit them exactly. There are some surgical procedures for varicose veins with regard to either cutting them out, sclerotherapy, which involves injecting high-dose saline into them, various options to go through. Venous ulcers are kind of the worst of the worst in terms of venous insufficiency, whereby the venous insufficiency is so bad that it's the underlying cause of the development of an ulcer. So these wounds, which can start from trauma or some type of pressure or something else, have as their foundation the lack of good venous return to promote proper blood flow, removal of wastes, and healthy tissue. Now, technically, ulcers can be kind of subcategorized into venous versus arterial. If you have to guess clinically, guess venous ulcers. Venous ulcers in the setting of venous insufficiency, way more common than arterial-based ulcers. And this next slide actually helps you compare and contrast between the two types. Just take a minute to kind of compare and contrast between venous and arterial ulcers. What I'm going to tell you is the broad overview. What's going on with the basic pathology here? In an arterial-based ulcer, there is insufficient blood delivery to peripheral tissue. That lack of blood delivery leads to tissue death, tissue necrosis. Contrast that with venous-based ulcers, where poor venous return kind of in a way leads to too much fluid buildup, blood buildup, lack of waste removal, stasis dermatitis, tissue changes from poor gas exchange, poor nutrient exchange, because you're not moving anything out. Almost like blood overcrowding. Arterial ulcers, not enough blood getting to tissues. Venous ulcers, not enough blood being removed and taken away. Kind of the opposite phenomenon pathologically. And talking about venous insufficiency lends itself very nicely to talking about a phenomenon called lymphedema, which is a tricky name in my opinion, because if you just look at the word, you would think, oh, the lymphatics and the lymph nodes are swollen and full of fluid. Not the case. What this term means is edema caused by the lymphatics and lymph nodes' inability to drain tissue. So people are not edematous within the lymphatic vessels. It's that the lymphatic vessels can't drain tissue, so fluid collects in the third space. Lymphedema is most commonly caused by trauma or surgical removal of lymph nodes. For example, in patients with breast cancer who have radical mastectomies, part of the procedure is to remove the lymphatics of the axilla. One of the postoperative risks is the development of lymphedema on the operative side because of inadequate lymphatic drainage of the arm. You may hear the term elephantiasis used clinically. I'll be honest, I think it's getting a little bit antiquated. If you do hear it, just know that elephantiasis is just really, really, really bad lymphedema. That's it.